Okay, it is 5:01 on Central Time. I am Tim Urgo. I'm a faculty at the University of Chicago and the current chair of Education Committee for CHEST. I welcome you to this webinar on tracheostomy. It's really a pleasure for me to introduce the panel today. But before we go into that, I want to tell you a little bit about why we're doing this. We learned a lot in the last really 24 months about tracheostomy. I'm reflecting on our experience from last year when we were debating even if we should do tracheostomy in patients suffering from COVID ARDS or not. There were several societies that were releasing statements, many of them opinion-based and some evidence-based. A lot of debate was ongoing in the literature about the need and value of doing tracheostomy safely in these patients. And honestly, as I'm thinking about last year, I'm not totally convinced that the philosophy of care and philosophy of safety were completely aligned in the beginning of the pandemic. But we're here to learn a little more about trachs, not only related to COVID-19, but in general, the optimal timing of tracheostomy, review the pros and cons of new devices because there are new trach tubes available on the market, highlight the key differences between the percutaneous technique and the surgical technique, and also methods of how to troubleshoot several complications related to the tracheostomy. So I want to introduce the panel. It's really a pleasure to have with us Dr. Carla Lamb, who is the Chief of Interventional Pulmonology at Leahy Clinic, and also a leader in CHEST and in AABIP, the Society of Interventional Pulmonologists in United States. Dr. Lamb will talk to us extensively about algorithms of care post-tracheostomy. Before Dr. Lamb, the speaker will be Dr. Kate Javarovich, who is also an interventional pulmonologist at Leahy Clinic. She will talk to us about timing and techniques of performing tracheostomy. And then at the end, we'll have Dr. John Gillard from Wake Forest University. Dr. Gillard is an intensivist and also part of the difficult airway group at CHEST, and he will talk to us about weaning patients with tracheostomy, especially those patients who are also on ECMO, which is a highly debated topic about what's the right sequence for weaning those patients of the machine. The way we're going to do this, we're going to have each speaker talk for about 10-12 minutes, and then we'll take questions, and then we move to the next topic. And then at the end, if we have more time for interactions, we'll do that. Meanwhile, as you hear the speakers, I will be taking notes and I will monitor the chat room. So if you do have questions, please ask them in the Q&A section or in the chat room. And then it will be my job as a moderator to ask the panelists those questions and summarize them for them. So without further ado, I want to pass the microphone now to Dr. Javarovich to talk to us about timing and techniques of tracheostomy in 2021. Dr. Javarovich.
So thank you for having me. My name is Kate Javarovich. I'm one of the interventional pulmonologists, like Dr. Murgu said, from Leahy Hospital and Medical Center in Burlington. And next 10 minutes, we'll go over, the objectives, the timing, primarily timing in COVID patients for tracheostomy, different techniques like percutaneous dilation tracheostomy and NYU technique, a surgical approach, and the new low-volume, low-pressure cuff tracheostomy tubes, and the pros and cons of these. We'll start with, indications for tracheostomy. And prior to COVID-19 pandemic, about 5 to 10% of ICU patients require prolonged mechanical ventilation. And this number increased because of increase in volume of cases from COVID-19 pandemic and patients with respiratory failure requiring mechanical ventilation. Up to date now in the US, there's about 44 million patients with COVID, and 10 to 15% of these patients require invasive ventilatory support. There's other indications for tracheostomies like airway obstruction, setting of trauma, and a setting of malignancy, obstructive sleep apnea, and those are not to forget. So we'll move on to timing. The tracheostomy timing really depends on the contributing factors. And these contributing factors are based on disease pathogenesis, patients and family preferences, expected outcomes and course of illness, and really what's the likelihood of weaning from mechanical ventilation for these patients. And the timing has evolved over the last 2 years, but also the early and the late tracheostomy timings were studied, prior to COVID-19 pandemic. And early is considered less than 10 days, and late is considered more than 10 days. So in early tracheostomies in prior studies, this is pre-COVID, show that there's shortened mechanical ventilation, there's increased patient's comfort, there's reduced sedation requirements. But it did have low evidence or inconsistent evidence for improved survival, decreased ICU length of stay, and decreased respiratory tract infections. But what we have learned during COVID, and the reason why it has been, like Dr. Margu said, a hot topic, is because tracheostomy is a super spreading aerosolization event, and healthcare workers can be at risk. So the timing has significantly evolved over the last 2 years as we learn more about the virus and the outcomes. And really what we've learned is that the peak infectivity is about 1 to 5 days of symptom onset. The decline in replication of the virus really starts after day 10, so day 10 to 15. But what's also very important is that ICU mortality for these patients is high, 58% within the first week. So one has to weigh, the complications from prolonged mechanical ventilation against the risk, of viral exposure to healthcare workers when considering the timing of tracheostomy. We'll review next 3 studies that looked at timing. One was from Italy, and this is WEAN tracheostomy trial in 2021. This trial had 150 patients, 53 patients. It was observational, retrospective, multi-center study. Their primary endpoint was mean time to tracheostomy, which for them was about 15 days. And their secondary endpoints look at all things we mentioned: survival rate, ICU length of stay, and then post-tracheostomy complications, in which they stratify by timing, early versus late, and technique that was utilized, percutaneous versus surgical. So what they did find was that there was no difference in survival between early versus late tracheostomy, which consisted with pre-COVID studies, and or whether this was percutaneous or surgical. But what was found that the early and percutaneous tracheostomy shortened ICU length of stay. But again, it did not improve the primary outcome. The next study was published in JAMA Otolaryngology in 2021, and this was from Spain, smaller study, about 50 patients. And this study looked at median time from intubation to bedside tracheostomy to bedside surgical tracheostomy. And the timing was 9 days, so considered to be early. And what they looked at, besides the surgical techniques, is infection among surgeons. And they tested the surgeons weekly for 4 weeks post procedure, and they did not find that any of the surgeons got infected with COVID. And this is, again, for early tracheostomy placement. The third study is from NYU Hospital by Hell, that was published in Critical Care Medicine very recently, July 2021, much larger, 394 patients. And they looked at their early median time was about 9 days, and late median time was 19 days. And the primary outcome, again, they looked at time of mechanical ventilation, length of stay, and survival. And there was no difference in survival, yet again, between early versus late tracheostomy. But compared to late percutaneous tracheostomy, early percutaneous tracheostomy had higher discontinuation rate from mechanical ventilation. And that's important. What also important to say about the NHealth study is their inclusion criteria. And the inclusion criteria, patients, to summarize, were overall stable. So there's no significant extrapulmonary organ dysfunction except for potential need for dialysis. They're on very low dose of vasopressors. There's no active bleeding secondary to severe coagulopathy. and there are unstable ventilatory requirements prior to procedure, which I want to lead to, stable pulmonary status is really essential prior to performing prior to performing tracheostomy, which leads us to different techniques. So there's surgical and there's percutaneous technique. And percutaneous dilation tracheostomy is now routinely performed and it has low complication rates, low infection rates, shorter procedural time, it's cost effective, and it's done under bronchoscopic guidance. During the COVID-19 pandemic, the new NYU technique was developed, and this technique utilizes the bronchoscope that's placed through the vocal cords anterior, as you can see here on the right, to the endotracheal tube, not through the endotracheal tube. And the endotracheal tube is advanced distal to the distal trachea with cuff inflated instead of retracted back when the bronchoscope is introduced through the tube. So this technique, it really is meant to decrease aerosolization and to allow patient ventilation through most of the procedure. So to minimize, discontinuation from ventilation. The surgical tracheostomy technique, of course, is open procedure. Anatomy is very well visualized, and we'll talk about next the pros and cons of the surgical technique and the percutaneous technique. So the pros for surgical tracheostomy, there's no need for bronchoscopy, number one. Entry in trachea is quicker, there's no need for dilation, and there's potentially lower risk for aerosolization. The cons is that not every OR has negative pressure capability. There's potentially, this requires potentially more medical staff like anesthesia team or nursing, transport team, and there also a risk of aerosolization on the way to transport to the OR. The percutaneous dilation tracheostomy has its pros and cons, and it has less bleeding. There's no need for cautery. It can be done at the bedside. Patient does not need to be transported out of the intensive care unit. Can be performed by non-surgical physicians that are trained in percutaneous tracheostomy technique. And NYU technique may reduce aerosolization, specifically in COVID patients. The cons is that if there are significant paratracheal vessels, there can be bleeding during the procedure, but that can be prevented by utilizing ultrasound prior to the procedure to identify those. Sometimes anatomy is prohibitive, and we'll talk about this in the next slides. And sometimes loss of airways due to premature extubation can happen. Which brings us to contraindications to percutaneous tracheostomy. Most importantly is unstable patient. If the patient is on high ventilatory support and rising, multi-pressor shock, that is complete contraindication to percutaneous tracheostomy. Infection of wall of the neck. Some of the relative contraindications, which leads us to prohibitive anatomy, is really obesity. Obesity in itself is independently associated with complications from tracheostomy, and it's loss of airway, malposition, and this is whether it's done percutaneously or surgically. And the higher the BMI, this risk increases. Bleeding diastasis, ideally, the platelet should be about 50 and are less than 1.8. The heparin should be held 4 hours prior to the procedure, and also limited neck mobility. Trauma patients, severe kyphosis, contracture patients, during the percutaneous approach, the neck is extended, but if one is able to palpate the anatomy well, the procedure can be performed. This is why it's relative contraindication. And also prior neck surgery, again, with distorted anatomy. But most importantly is one should utilize the technique which minimizes aerosolization, especially in COVID patients, and it should be based on institutional expertise for the procedure and defined protocols. So we'll move on to low pressure cuff, low volume tracheostomy tubes. So these are, for our institution, these are newer. And the goal of this tracheostomy tube, as you can see here on the bottom right picture, it's tapered shape, tapered guard cuff. And the goal is to minimize tracheal impact and decrease tracheal injury that can subsequently cause tracheal stenosis. It exerts about 18% less lateral wall pressure, and this was in the device studies done by the company. It is more effective at fluid and air seal and requires less force to insert. And again, this is done in the models, not in human models, in device company. It has larger inner diameter, and the airflow is actually significantly increased about 200% around the outer cannula when the cuff is deflated, which is very useful for patients who are ready for passive mirror speaking valve trials. What we have encountered is, at least in our institution, that there's been increased cuff leaks, displacements of these tracheostomies, and the thoughts or maybe the taper cuff fits differently in patients' airway over time. Maybe there's decreased airway edema as the patient is improving, or is there a component of tracheomalacia at the tracheostomy cuff site. So for troubleshooting, what we have done is, and the company's recommendation actually is to add air into the balloon, and the amount of air they recommend is higher than what we typically put in. For 8 size, about 17, 16 for 7, and 14 for 6, as you can see here on the right. But the goal is to not exceed balloon pressure above 30, so to keep it between 20 and 30. If that has not worked and the cuff leak persists, what we typically do, we exchange the tracheostomy tube for the same size, to see, to confirm that the cuff is intact and the pilot balloon one-way valve is not faulty. And if that has not worked, then we lastly exchange to a longer tracheostomy tube, like a distal XLT. And that's typically our algorithm for this. And obviously that depends on the timing of placement of the tracheostomy tube and where the patient is in their algorithm. So to summarize, what I wanted to have everybody to take away from this, the timing really should be based on patient's factors and stability. And that's COVID, whether it's a COVID patient or non-COVID patient, there's no difference in survival between early versus late tracheostomy, at least from the most current studies. And that early tracheostomies in COVID patients do decrease ICU length of stay, they shorten length of mechanical ventilation, and that there is no increase in risk of COVID infection in medical staff when proper PPE and protocol for the procedures are in place. And then for the techniques, the institute, you should utilize, the techniques that minimize aerosolization, and it's based on institutional expertise and defined protocols. So I want to thank everybody, and we'll take questions.
So, Dr. Javarovic, there are at least 3 questions for you, and I appreciate you staying on time. The first one, I'm gonna throw them in the order they came in. So the first one was related to the PEEP level, and I know you had a slide on this, but the question was like, how does the high level of PEEP impact your decision in regards to timing of tracheostomy? And a related question is, what would be the contraindications to a tracheostomy in regards to FiO2 and PEEP?
I think it's, institutional based, what we have done, and I think what some of the society guidelines have recommended for patients that are on higher PEEP levels than 12 is to do the, inspiratory pause maneuvers for 30 seconds and see if there's desaturation, because really that's what you want to avoid during the tracheostomy placements. And in our institution, we don't perform the NYU technique. We do the standard percutaneous bronchoscopic guided tracheostomy technique. So there is interruption of ventilation during the procedure. So we always want to make sure that there is no emergencies during the procedure that could be, prevented. So we do inspiratory pause for patients that are on higher PEEP. Ideally, for us, PEEP should be less than 15. Less than 12 is, of course, even more ideal. FiO2, I think, patient has to show stability over time. So this is where the time frame, early versus late comes in. If the person is stable, with stable O2 requirements, they can undergo early tracheostomy. And if they're obviously escalating O2 requirements, unstable, then they're potentially going to be in a later category.
Yeah. I think I think in your slide, the parameters that were included in some of these studies, especially for COVID patients, were like P less than 10 and the FiO2 less than 60%, which is not that much different than the prior literature. Questions keep coming in for you, Dr. Javarovic, so I want to make sure we address our participants' needs. So when you refer to obesity as a contraindication, to relative contraindication to tracheostomy, what metrics do you use to define obesity? And I mean, is it just the BMI or has to do with the actual laryngeal anatomy?
I think for us, it's, there's 3 studies in the literature, and I didn't show that slide, but different BMIs. They stratify people by different BMIs. And for us, it's being able to identify the tracheal anatomy with neck extension, so that's why it's a relative contraindication, not a complete contraindication. If one is unable to palpate the anatomy, for us, that's a contraindication to bedside percutaneous tracheostomy. And then in those cases, we would have our surgery ENT colleagues weigh in on the case.
That's a very, very, very wise remark. And we often get called to do trachs, and people say, well, but the BMI is greater than 40. And my reflex question is, have you examined the neck? For the exact reasons you mentioned. Okay, and then last 2 questions, and maybe we can answer them in a couple of minutes here. Can you insert an extra long tracheostomy using the Cook kit? And as you're reflecting on that, any opinion on the water versus air cuff? Okay,
so we have inserted, our tracheostomies don't come in the same kit. I think you have to be aware that the extra long distal XLT, or whether they're proximal, the end of the tracheostomy is not as tapered as the newer tracheostomies, and they're slightly bigger in diameter, so you might have to dilate for longer. But that shouldn't be. I would have to look at the specific kit that's being used, primarily. So the Cook kit should not matter for the type of tracheostomy that you put in. You just have to make sure that you dilate for the size that you're putting. We typically put in 8 Shileys. And unless the patient is very petite, then the 6 size goes in. But 8 is our typical one.
Yeah.
The longer tracheostomy tubes, we don't tend to go for those from the get-go unless there's very specific reasons for that.
Mm-hmm. On a personal note, as we're doing more of these, and we had similar issues with the leak with the new designs. Just personal bias, institutional bias, we troubleshoot that by sometimes placing the XLTs. We realize they align with the airway wall a little better. So they're a little more coaxial than the newer trachs, but that's opinion based. So absolutely doable to insert an XLT, either proximal or distal, during the percutaneous technique. All right, it's 5:24. I want to be cognizant of time. Thank you, Dr. Javarovic. Obviously, stay on because we may have more discussions coming up. Next speaker is Dr. Carla Lamb, who will talk to us about post-tracheostomy care and long-term follow-up, now that we learned about the timing and the actual technique. Dr. Lamb.
Great. So I want to focus now on several things about tracheostomy care, post-placement care, troubleshooting in those scenarios, and even established pathways to decannulation. And so with that, I hope to leave you with some practical tips, some updates from the literature, and where do we go from here. I think that, one thing that COVID has clearly done regarding tracheostomy is it has bonded indelibly our multidisciplinary teams. It really put a spotlight on tracheostomy care because we had unprecedented numbers of patients in the setting of COVID pandemic with tracheostomies that needed to be managed in the hospital setting where they were not going promptly over to LTACs. And so I think that gave us an opportunity to really refine pathways. And I think that may be something we all have found from that. So again, who are the stakeholders? Well, I've listed a this is not all exhaustive, but it's important to have at least these stakeholders at the table in communications as you're building pathways and as you're refining the pathways. So post-tracheostomy care, some of this seems, in some level fairly basic, but there is a daily care routine that the nurses do and our respiratory therapists undergo. And the most important thing is to be intentional about paying attention to the tracheostomy, underneath the flanges, making sure there's not tension on the trach, especially after it's been immediately placed, to reduce complications and avoid them and prevent them. And by keeping the site clean and dry, making sure that you're not leaving patients with wet, saturated dressings, that you're in a timely way changing those, can help reduce some of the potential complications, which are significant with decubitus ulcers that can be avoided. And keeping the area clean, dry, and really managing secretions. And if you're having difficulties, meeting with those who place the trachs to partner with the multidisciplinary team to try to find solutions for that particular patient and scenario. Now, this is actually from the pediatric literature that really did demonstrate that there was reduction in pressure ulcers. And again, not just from the dressing itself, but clearly having an absorptive dressing that kept a barrier between skin and flange was very important to reduce the likelihood of developing a decubitus ulcer, which is a high stakes complication because it is a reportable event, because it does, set the tone again for decubitus ulcers. All those things can be reported and are significant to avoid altogether. This is just an example highlighting any particular type of foam wicking gauze or we call this is actually a Mepilex or a version, and the lines really signify where if the patient has a sutured trach, you can actually accommodate by creating kind of custom cuts in the foam dressing just to accommodate that no parts of the flange are touching the skin. This is just a care bundle that has been adapted. This is from Johns Hopkins, but we've actually modified and adapted it to our own. But this has really a checklist so that every person who's caring at the bedside for the patient has a standardized checklist to go by to, really prevent wound care and prevent wounds in the first place. And I think this is very helpful to have a standardized pathway in that regard. This is something that we had developed and refined over the years. This is actually a bedside sheet. We made it neon pink so that it was easily recognizable, so that at the head of the bed of the patient, if the patient has any problem with the trach, either in the ICU or floor setting, there is a way to know who owns the trach, when the trach was placed, can they be intubated from above, emergency numbers for an airway code should it be needed. And we keep this updated in real time based on the patient's trach size, and if there's interval changes, it's just another layer of communication about what size trach and what type of trach a patient has. This is our emergency kit. In this kit, every patient who has a new trach, actually every patient who comes into our institution, whether it be a new or prior trach, they have a box at the bedside that really simply has all the trach supplies for emergencies. 2 cuff trachs, one the same size the patient has and one size smaller. So if there is an airway emergency, this can be found readily by all care providers so that you really reduce time lag and delay. This is just an order set that I think I would encourage every institution to have a electronic medical record order set for several reasons. It standardizes your processes after care. It also puts a benchmark in to consider speech path consultation in patients who've been trach collaring for at least 24 hours, and you can integrate that in a very seamless way. This is just an example of that. I think, as was mentioned, another take home from COVID is that we learned how to be creative with applying heat moisture exchanges and making sure that not only humidification and filtration were really paramount during the COVID pandemic as we continue on with that. And it continues whether they're on a ventilator or not when they have a tracheostomy. And these are just some creative ways of maintaining either an open versus closed suctioning in the COVID pandemic to really protect care providers and minimize aerosolization while still providing adequate humidification to prevent obstruction from secretions. So I'm going to roll into potential complications in the aftercare period. We really separate the complications between immediate, early, and late. This is not all exhaustive, but it's pretty comprehensive. And I'm going to highlight some of the key features with probably the top 3 that everyone should have their team trained and be knowledgeable about. So I say get into the sim lab and put everyone into place with building your multidisciplinary team. Repetition is key. And this is one of the resident training programs we set forth for all of our medical residents, incorporating our respiratory therapists, our nurses, and our residents and our experts in trach management and care and aftercare. So let's highlight 3 of the big airway emergency situations in patients with trachs: the bleeding tracheostomy, the trach tube obstruction, and potentially accidental decannulation. So I think when we think about bleeding, we can think about early causes for bleeding and late causes for bleeding. And I think you have to go into it with an open mind, because your job is to, you never want to ignore bleeding from the tracheostomy. You never want to assume it's just from suction trauma. You want to really define what the cause is and get to the bottom of it as promptly as possible. I think that's really important. I think here, certainly the innominate artery, that can be a devastating complication, and it can be preceded by just a small amount of bleeding and then rapidly become really a waterfall, if you will, of disaster that can be managed, but it really requires a low threshold for suspicion of it and also a quick management plan to activate. But the prognosis can be quite poor and has a high morbidity and mortality. So I think when we think about it, the likelihood of this happening is relatively low. And I would say, in a minute, I will caution you to think about, use all the data you have prior to your procedure planning, because you may identify aberrant anatomy with bedside ultrasound or prior CT scans the patient has to inform you about how you approach a tracheostomy, whether it may not be percutaneous, but it may require surgical tracheostomy approach. But I want everyone to be knowledgeable about this potential complication, really be mindful about how you image patients at bedside and with the data that you may already have. So this is just a reflection briefly on the anatomy that lives in the space. And I have an example here of a patient that we were consulted on for perc trach, and the big red arrows highlights there was a large innominate vessel just sitting right in the midline of the trachea. So that would inform us to go with a surgical approach, not a percutaneous approach. And even those can be higher risk just based on the anatomy in and of itself. So how do we think about bleeding management? Think of any of these airway emergencies as an airway code. When we think about bleeding, we want to have all the right people at the table. You want to protect the airway, maintain the airway. If you lose an airway, reestablish it quickly. And there's some just practical tips that you can begin to do as you get called to bedside for a bleeding airway. And this really falls into a hemoptysis algorithm as well. And I think having plenty of equipment available, suction available, saline, which I'll allude to in a moment, I'll give you a triage step by step. So again, assess quickly, where's the bleeding coming from? Is it peristomal? Is it from the trach? Is it from the deep airway? Is it the oral pharynx, the nasopharynx? Is it even the GI tract, for example? Correct any coagulopathies. In the midst of the chaos, sometimes that gets overlooked, and that needs to be done simultaneous to your triage. Provide them full vent support. Be prepared to intubate from above and abandon the tracheostomy potentially. But again, you don't want to lose the airway. So again, a bronchoscope is imperative here. And we'll talk about topical applications to the airway as well in the bleeding patient. In the midst of things, it's probably a really good idea to overinflate the cuff and inflate just to see if you can tamponade off bleeding while you're trying to sort out and clear the field to localize where the bleeding's coming from. And then again, we have a hotline for an airway code. So we know when a code for an airway is called, people come with other devices, assuming difficult airway, bronchoscope, surgical colleagues, anesthesia colleagues, everyone comes to the table. Now, I'm going to mention saline. It's very quick, easy to access. TXA, it takes a little time to get it up from the pharmacy. But again, we typically think of TXA used in non-massive hemoptysis, but it still can have a role in any form of hemoptysis. It's a 500 milligram. It can be squirted down the bronchoscope topically with or without saline, typically in a neb form, it's mixed with saline, but in this kind of acute emergency, you could topicalize it just by squirting it through a working channel of a bronchoscope. So again, this is kind of my go-to checklist of airway code. Again, being prepared to intubate from above if you need to, correcting coagulopathies, using topicals, and then getting the care team at the bedside. This is just to highlight the key points here. This could happen during a tracheostomy, but it could also happen after the fact. And still the same thing applies. Hyperinflate the cuff, apply pressure at the stoma, sternal notch pressure, sometimes with a gloved finger, and then being prepared to intubate from above. But really, you want to use the tracheostomy if it's viable for oxygenation and ventilation, maintain it, but overinflate the cuff to create a tamponade if you've localized bleeding in the trachea itself. This is actually a pretty good checklist, I would say, of all the different things you can use. I think my go-tos are cold saline as well as TXA for the reasons I've already mentioned. And then sometimes there's need for wider intervention from advanced bronchoscopy or interventional pulm. So just another little scenario. Say the nurse calls and explains that the patient who was trached 5 days ago is now in distress. They've observed the trach tube was not resting flush to the skin, so they actually attempted to advance the tube flush to the skin, which it was able to be advanced. They performed an intercannula change, but they, for some reason, cannot pass the suction catheter down the trach at this point. What could be going on? So you really want to have a checklist. Could it be trach tube displacement? Could it be in a false track? Is the intercannula obstructive for some reason, but they said they could change the cannula? Could it be a tracheoesophageal fistula or an infection of the stoma site? Well, in this case, what do you do while you're sorting things through? Again, provide ability to ambu bag. And here's the thing that I would highlight. Sometimes when a patient has the tracheostomy, everyone kind of gets tunnel vision that all paths for ventilation are only via the trach. But in this case, when the trach is no longer deemed reliable, you have to start moving toward being prepared to orally intubate. That's probably the true north of all these type of airway emergencies, is be prepared to reestablish the airway minus the tracheostomy tube if it's not been able to be made viable again. And again, the other things that I would highlight here is when we talk about trach tube obstruction, be prepared to be intubate from above. Oxygenate while you're triaging. Try to do a few things with replacement of intercannula, but if you can't pass the suction catheter, that means there's some type of physical obstruction, either the trach's up against the wall or you could very well be in a false tract. And this is just a highlight of this. This is actually a case, if you look very carefully, you'll see there's a tracheostomy flush to the skin, but it is clearly in the anterior tract, not in the airway whatsoever. And even when this was inspected bronchoscopically, they saw this tissue, but they did not recognize airway. So it's important when you reestablish an airway that you confirm in two venues, CO2 exchanger for CO2 exchange, and also a bronchoscopic image to assure you are back in the airway space. And again, there's the tracheostomy there. So again, tube displacement, we've talked about, again, especially the early trach, if it's less than 7 to 10 days old, the tract likely is not mature enough. And so it would not be recommended to an inexperienced person to try to replace the tract. It's always your safest bet to intubate from above and then cover the stoma and advance the ET tube via the airway below the stoma site. So what are the causes for accidental decannulation? Delirium and agitation is probably the most common cause. They often are vulnerable at shift change to the patients, and not having someone owning the airway when a patient's turn for bathing or daily care. It's really important to build a team where it's a mandate that someone's not just looking at the tracheostomy, but there's someone holding the tracheostomy in neutral position with slack on the ventilator tubing to assure that there's no jostling of the trach. This is just a nice algorithm breaking it down by what could be done when there's unplanned dislodgement of less than 7-day-old trach between 7 and 30 days and greater than 30 days. The thing you want to look at, just like with any ACLS approach to a patient, is the patient stable or unstable? If they're unstable, you're calling a code, you're getting the people to the bedside to help you, and you're preparing to intubate from above. If they are stable, then you have more options, as alluded to here, where you can do a bit more of a stepwise approach. But the key is to have an algorithm and be able to move quickly through that algorithm if the one pathway is not working. So planned decannulation, just as we move through this, there's really no robust randomized controlled trials here, but how do we move our patient through appropriate decannulation? And another highlight of COVID, I would say, is that we identified that we wanted to move patients from intubation to trach to as rapid as their medical conditions would allow to move toward decannulation for a number of reasons, namely for a patient-focused approach. And I think that's also added a spotlight to how we think about fast-tracking decannulation. And I think things that will come from this are from COVID, actually, and the care of the trach patients, that maybe we'll have more standardization and more trials and results of those trials that will be efficacious. But it's clear the advantages. Patients can communicate and they can swallow and eat and progress through their care plan. It really brings back the humanity to the patient. So I think it's important here. There's different ways of doing it, but I think it's a stepwise approach. The tract needs to be mature. They have to be trach coloring for at least a good 24, 48 hours. Speech path gets involved. And then from there, we move forward with the Passy-Muir speaking valves and then go on to capping trials. Publication in 2014 from Laryngoscope identified if you did a stepwise approach like that and they capped for at least 24 to even 72 hours after being downsized from, for example, an 8 to a 6 and then even to a 4, if they could tolerate Passy-Muir valve for 24 hours and have phonation and move on to the true capping trials, they were uniformly successful with their decannulation of their tracheostomies. So again, just to wrap up, progressive downsizing, it's slower and cleaner, but I think that there's room in every patient individually to consider some patients who can be fast-tracked. It really depends on what was the reason for the trach in the first place, and based on that, has that problem resolved? And that also informs us how fast we can actually go realistically to decannulation and downsizing. And I'll just wrap up with this. When we think about decannulation, Passy-Muir valves, we have to remember even the speaking valve reduces tidal volume by 50%. Patients have to be taught again how to phonate. If they're not passing these maneuvers, it could be that they now are experiencing something supraglottic obstruction, granulation tissue, even tracheostenosis, especially in the COVID world. We're starting to see publications, although small in number, reporting tracheostenosis, laryngeal tracheostenosis from the prior intubation even, that are leading to complications and failure to decannulate. And sometimes up to 47% of patients who had COVID in the prolonged ARDS ICU stays. Again, capping trials are imperative, as I've mentioned. And I'll just roll through just a few sites just to identify for everyone. When we think about where patients can have stenosis, this is from the endotracheal tube more proximally, but from the stoma, it's going to be at the top of the stoma typically, or where the balloon of either the ET tube or the tracheostomy tubes are placed. And with that, I'll wrap up with tracheostenosis. Again, if a patient's failing a speaking valve trial, they could very well have a structural problem with their vocal cords. It really is imperative for inspection. And I will stop there. Thank you for your time, and I hope there'll be time for questions. And I'll stop sharing my screen.
Yeah, thank you, Dr. Lam. Lots of questions coming in. Dr. Javarovic tried to answer a few, and she did, but I know many of these are for you. You mentioned neck evaluation for looking for innominate. What about, first of all, do you use ultrasound routinely prior to the trach?
Yes, we've made it part of our standard of practice to look at that. You look at all the anatomy surrounding. I think it informs us about vessels and depth of trachea as well. Mm-hmm.
And follow-up question there is, if you see just small vessels, not necessarily the innominate, does that preclude you from intervening, or you try to avoid them? Walk us through the decision-making process.
Yeah, great question. I think that small vessels are not absolute contraindications. I think it's important to be prepared. Sometimes, a lot of times small vascular venous vessels along the thyroid and whatnot, if they're not in your direct field or they're kind of surrounding the point of entry, oftentimes your tracheostomy tube will actually tamponade small vessels and there'll be no issue with significant bleeding. We also will utilize a cautery stick that can be applied at the bedside if necessary, but we have a good relationships with our surgeons so that if we needed a vascular, tie-off, if you will, which is actually in my 20 years, I've not had to require that, but between a cautery stick, tamponade of the trach, we've been okay. And then making sure, again, reversing coagulopathy a priori before a procedure is kind of probably another helpful tool, but not an absolute contraindication with small vessels.
Yeah, and then to go on those on the same train of thought here, we inject Lido with epi, there is some swelling, we make the cut, and then 6 hours later, the swelling subsides, and oops, we have a little ooze. So one of the questions that came in is, any tricks for this early bleeding? Do you use Flow Seal or Quick Clot?
Yeah, we use one brand or the other where we're actually, it's a spray on. Sometimes those are very effective. And again, and sometimes creating a kind of a packing tamponade around the area. Oftentimes that venous small vessel oozing will self-resolve with that intervention. But yeah, we actually do use usually a spray form to help to cause cessation of the bleeding. Mm-hmm.
All right. Now, in regards to trach malfunctioning, let's say the trach is occluded, not working. What are the steps to intubating people? Do you remove the trach and intubate from above, or you remove the trach and put the ET tube through the stoma? Tell us about your practice and what you think is the safest approach.
Right. So it depends on the patient, right? So that's why that pink sheet's so valuable for us. Can we actually intubate this patient with a faulty trach at the bedside? That's paramount, because if you lose the airway, you don't have the skill set to put things back together, the patient can cause death. So I think the first thing I ask, can I intubate from above? I prepare to intubate from above. I actually will remove the tracheostomy tube, cover the stoma as I'm intubating from above. We'll have an extra pair of hands doing that and create a pressure dressing over the stoma and make sure the ET tube is advanced beyond that. Now, if there's a question about difficulty of intubating from above, absolutely, you often will have to cut the proximal length of the ET tube, introduce it with either at the bronchoscope and bronchoscopically intubate into the tract of the stoma itself and secure that. And oftentimes we'll even suture the ET tube in the short term via the stoma if there's no great pathway to get in from above. So I think it's really patient specific, and then again, that's where you're going to have a team working together to implement that so that you don't lose or you can't regain the airway.
And then I'm trying to compile here 3 questions in one, so we can move on. It has to do with timing for the Passimier valve, timing for cannula exchange. And when you're referring to a fast track to downsizing, what do you actually mean by that?
Sure. So I think the first step is, before we can even talk seriously after a new trach has been placed, to do any kind of downsizing, you want to have a mature tract at the very least. So we're talking 7 to 10 days, depending on what type of trach it is, and whether it be PERC trach, usually I err on the side of a longer time, 10 days as opposed to 7 days for surgical. The other question too is, what drove the patient to the trach reliably resolved? Can they maintain their management of their secretions? And also, can we have they been trach collaring? Have they no longer they're no longer event dependent even at night? So if they trach collar 24/7, at least 24 to 48 hours, we begin a speech consultation and begin the conversation about working toward downsizing from an 8 to a 6, and then 6 cuff less. That's an important point. Believe it or not, the cuff of the tube can really be a showstopper for patients to be able to use the speaking valve. So you have to make sure the patient is ready to go to trach collar. They're trach collaring successfully, downsize to a cuffless, size smaller, and then begin the speaking valve trials in conjunction with the speech team. And I think the key for fast track is for the physicians to be, again, the order set kind of takes it out of our hands a little bit, because as soon as the patient's trach collaring for that first 24 hours, we begin the launch of the speech consultation. That way we can get things going, partnering with respiratory therapy, nursing, and speech. I think sometimes the medical providers may be slowing the process down. I mean, there might be times where a patient has gone back to the LTAC with their original 8.0 trach and never had that initial trach change or catheter or downsized. And I think that's a real hazard, because that's not a service to the patient. So we should always be mindful to do that in a very timely way, because I think the last thing you want to have happen is a patient trached with their 8.0 trach who never got to the point where they actually had their first exchange or downsize.
Dr. Lam, thank you. It's truly a marathon here, and I feel like we can talk about post-trach care for another hour, but we do need to move on. I will let you actually answer the questions in the Q&A session there, as Dr. Gillard will talk to us about trach and ECMO. Challenging topic, challenging patients to manage. Dr. Gillard.
Great. All right. So thanks for introducing me. Thanks for having me, Tim. I'm John Gilliard. I'm one of the cardiac intensivists here at Wake Forest and the director of ECMO for adults. I'm going to be a little different than the other two topics, but talk about trachs in ECMO patients. Now, I'm mainly referring to patients that are put on ECMO for respiratory issues, really because the cardiac patients, at least the adults, aren't on ECMO for that long. I'm also mainly referring to patients with acute respiratory failure and not those patients that are chronically hypoxemic and put on ECMO as part of their pre-habilitation prior to getting a lung transplant. I have no disclosures. I am a faculty member of the Difficult Airway Group and receive honoraria from CHEST for my participation. Here are the objectives. We'll start with the basic question of, should we be doing trachs on patients that are on ECMO? Then we'll talk about what is the best timing, as well as the different techniques. And finally, we'll talk about ventilator weaning for patients that have been trached but are still on ECMO. We all know about the potential benefits for trachs. Kate told us about that a bit, versus keeping an endotracheal tube. We want all of our vented patients awake, comfortable, and working towards improving their oxygenation and ventilation so that they can get off of the vent. All of these things sound great, but there's one problem for ECMO patients: bleeding. If you work with ECMO patients, then you know that you always have to constantly assess whether or not the blood is too thick or too thin. The pump and circuit are incredibly thrombogenic, even the heparin-coated ones. If a clot stops the pump, the vent might not be able to effectively oxygenate the patient, and that has bad outcomes. If you make the blood too thin, you certainly risk the patient bleeding. Usually it's minor and we can deal with it, but major bleeding is not uncommon, especially with these longer ECMO runs of weeks to months. So what should we be doing? Well, the literature, what literature there is shows that the benefits really outweigh the risks. We should be traching these patients. You worry about bleeding whether you're doing a procedure on an ECMO patient or not. For trach, evaluate each patient's particular anticoagulation need and adjust it as necessary to minimize bleeding. This may mean holding anticoagulation for some amount of time before and or after the procedure. There's not a universal recommendation as to timing because these patients are so complex. It really comes down to the individual patient. The main takeaway, though, is that we really should be traching our patients on ECMO. Regarding the timing of the trach, again, not much direct evidence for ECMO patients to support early or late tracheotomies. In practice, there's an incredible amount of variety. Sorry, tongue twister. Some people will do it on day 0. Some people will do it several days after decannulation. And these, again, are patients that have been on ECMO for several weeks to a month. Looking at surrogates for outcomes, though, earlier seems to be quote unquote better, but really more studies are needed to make a stronger recommendation. Looking at techniques, which is the best for ECMO patients? Should it be an open surgical trach? Should it be a perc trach? Should it be a hybrid combination of these two? If you are going to do a perc trach, should it be one dilation continuously or multiple dilations? It really depends on what we mean by what's the best. Here are 3 forest plots comparing different outcomes of wound infection, bleeding, and mortality by trach technique. For wound infections, percutaneous is favored and has some statistical significance behind it. But for bleeding and mortality, there's really no statistical difference between a perc trach and a surgical trach for patients on ECMO. Given these findings, I think a perc trach should be the default for trachs on ECMO patients, realizing that nothing is set in stone. As for dilations, there really is no literature about single versus multiple dilations for ECMO patients. From a logistic standpoint, and probably from my personal bias, single dilation seems to be an easier, faster, and so I would say better approach. Now let's look at ventilator weaning for ECMO patients. After initiation, ventilator management, we really focus on ultra rest settings. The vent is there essentially as a backup if the ECMO pump fails. Lung compliance goes to nothing. Your tidal volumes go into the double-digit cc's. But slowly over time, our compliance improves. First, we're going to see that the tidal volumes increase. Usually, but not always, CO2 clearance improves as the tidal volumes improve. And really, CO2 clearance is a true marker of return to lung function. When you start seeing that the lungs can support ventilation, you know that they're healing and you can wean the ventilator. There is some emerging literature about using transpulmonary pressure, but for ECMO patients, unfortunately, very little data, but it is promising for the future. So where does that leave us in terms of what we should do for our patients? Well, from the paucity of literature that is out there, I've come up with, at least the way I do it, single dilation, percutaneous tracheostomy within 3 to 4 days of going on ECMO. I individualize the anticoagulation to the specific patient. After the trach, I try to minimize sedation by around 48 hours post-trach. Unfortunately, this can be difficult in these patients that are acutely hypoxic because they're not used to the degree of hypoxemia and they're not used to essentially being on ECMO with a cannula as well as a tube in their neck. As opposed to the chronically hypoxemic patient who might be in line for a lung transplant. Those patients, it seems like they're much easier to minimize their sedation, but the acute ones, they really seem to have a lot more pain, agitation, and air hunger. So we try and do the best that we can to get them off of the sedation so that we can interact with them a lot more and start trying to get them some good PT and OT. And with that, I will stop sharing.
Thank you, Dr. Gaylord. I personally actually have a question. There are a few other questions there, I think, for the entire panel, actually, because they're still related to technique and managing problems. But one question that I have is someone who still goes to the ICU, several weeks a year. I always challenge about the sequence of weaning these patients. Should we wean off the ECMO first, or should we wean the ventilator first? Can you walk us through your decision making and what factors would favor one approach versus another?
Yeah, I really think it's patient specific, and I hate to. It sounds like a cop out, but it really there's such a wide variety of patients that we tend to put on ECMO? Are they obese patients? Well, they may need a lot more time with the pump and less time with the ventilator. Are they a little bit older? They have decreased pain receptors. And so, again, well, maybe we can really work with them with the ventilator. And so, like I said, unfortunately, it really is patient specific. My preference is to try and ultimately get the patient's lungs to essentially a good point, keep them on ultra rest settings for a long time, get them to where their lung function has improved significantly. And then when coming off ECMO, they'll essentially be on minimal rest settings so that we don't get back into all right, I've got high ventilator settings. Let me start beating their lungs again with high peak, high plateau pressures.
Yeah, and hopefully the ESLO registry will bring some light into that. Just before this webinar, we're chatting about that paper that came out in Lancet, right? That the ECMO use in the second part of the pandemic after May 2020 looks like it resulted in higher mortality than in the beginning of the pandemic, and makes you wonder why that is. And hopefully we'll learn a little more about the role of tracheostomy in these patients based on those registries. There are a couple of more questions, and then we'll have to wrap it up because we're on the hour. And I think they're related to the technique. So any of you could volunteer to answer this and share your experience. And one of them is, do you routinely bring the cautery when you do a percutaneous tracheostomy just in case there is a bleed?
I can answer this one. So we don't routinely bring the cautery, but we do, like Dr. Lamb mentioned, ultrasound ultrasound the neck prior to the percutaneous tracheostomy placement. So if there is a concern or risk, or if patient is more coagulopathic, we do some tracheostomies in cirrhotic patients, then that would be the cases that we would bring the cautery. Otherwise, not for every percutaneous tracheostomy placement. It's a case-by-case base.
Thank you, Dr. Javarovic. And then in regards to technique also, they're from the same person, Dr. Almadi, asking about the serial dilators versus just the cone dilator, because apparently in his institutional experience, when there was shortage about the cone dilators, and they had to use the serial dilators. Can you comment on that experience and practice? Any difference in technique or outcomes?
Yeah, I mean, I just find that, especially teaching the fellows and residents, if you have the ability for the cone dilator, the single dilator technique, I think it goes a lot smoother. You don't have to worry about losing the stoma. You don't have to worry about, looking at the tracheostomy site, then trying to look and find the correct dilator. I just, from a user-friendly place, I think it's a lot better.
All right, we're 4 minutes over. I do want to ask you each of you individually, like if you reflect on your tracheostomy practice, especially for the last year, I would say, what would be the one take-home message for our participants that's pertinent to your talk? So let's go chronologically here. We'll start with Dr. Javarovic.
I would say that, always take patient's factors into consideration. And, patients should be as stable as they can be for the tracheostomy placement. It does not improve survival, early tracheostomy, so just beware of that. But it does shorten length of mechanical ventilation and ICU length of stay in appropriate patient. And it's pretty strong with PPE and proper protocol, for your procedure.
Appreciate it. Dr. Lamb?
Yes, I think that, as I mentioned, post-trach care is as important as the decision-making to place a trach. And I think if you, at your own institutions, can really unify the multidisciplinary team, and you'll have to circle back many times, because communicating to a large institution and having that corporate knowledge, you need to build in redundancy of education. And so, but I think it will take the intimidation factor out of a tracheostomy. And I can't stress enough that triage of those big three, the bleeding trach, the obstructed trach, and the accidental decannulation. If we can educate all of our providers so that whomever's in the hospital 24/7 has a triage plan to begin with, and never forget to intubate from above. Do not get tunnel vision that the trach is the only point of entry, especially if it's not working.
Thank you, Dr. Lamb and Dr. Gaylord.
Yeah, just for patients on ECMO, traching them is safe. I recommend doing it earlier within the first 3 to 4 days. That way they're kind of in the tail of their surge response from the ECMO circuit, and their platelets tend to function better, and going ahead and getting it done, but making sure that you individualize the anticoagulation approach to minimize bleeding.
And I have two concluding remarks here. One, I want to thank the sponsor of this webinar, Cook, for allowing us to get together and have this, obviously with the help of CHEST. And then for those of you who are interested in learning more about the techniques and the science of tracheostomy, we actually do have dedicated courses at the CHEST headquarters. They are cadaver-based courses that are not only reviewing the literature, but also teaching the actual procedure in the most authentic model, which is a cadaveric model. So we welcome you joining us in the future months, because CHEST headquarters has opened up for small in-person hands-on programs. So I want to thank you all for sharing your expertise and reviewing the literature for us. And I trust you all stay safe and well, and be well. Thank you all.